Okay, so we finished with the fixed combination. We're now going into multiphasic combination. Are you awake? Okay, so in multiphasic combination, it also contains constant amount of estrogen, but variable dose of progestin. So progestin here is adjusted. Did you get that? Okay, constant estrogen, variable dose of progestin. So that is your multiphasic combination. And the number 3, mini pills. This only consists of progestin at a constant dose. So have in mind, constant and variable. So mini pill, constant dose of progestin, multiphasic combination, constant amount of estrogen, and variable amount of progestin. So what is the mechanism of action here of your oral contraceptives? Number 1, it will inhibit the mid-cycle LH surge. What is LH? Luteinizing hormone. So therefore, if there is low amount of LH, there will be no ovulation. You have this in your fissure, diba? Then number 2, it will thicken cervical mucus. It will thicken cervical mucus, making it inappropriate for implantation of a fertilized ovum. Number 3, alters secretory changes of the endometrium, alters tubal transport. By the way, where is the site of fertilization in the eye? Ampulla of the fallopian tube. And then after that, where will be the fertilized ovum go? Uterus. Okay? So, of course, having in mind that the fallopian tube tract has no constrictions. So, for example, if there is some constrictions in the isthmus, the fertilized ovum from the ampulla cannot be transported into the uterus. And this will cause what? Tubal pregnancy. Okay, so that's the mechanism how tubal pregnancy will occur. Did you get it? So, I repeat, inhibit mid-cycle luteinizing hormone surge, thereby inhibiting ovulation, thickens cervical mucus, alters secretory changes in the endometrium, alters tubal transport. Other kinds of hormonal contraception. Number 1, progestin implants. And this is exemplified by levonorgestrel. Number 2, postcoital contraception. High doses of ethinyl estradiol or diethylstilbestrol is given within 72 hours of coitus for 5 days. Again, how many ethinyl estradiol or diethylstilbestrol will be given? 5 days. And then how many hours after coitus? 72 hours. Okay. So you will have to count how many hours. Okay. Number 3, morning after pill. Morning after pill, 2 doses of ethinyl estradiol plus norgestrel. Hello? Morning after pill, 2 doses of ethinyl estradiol plus norgestrel are given 72 hours of coitus, followed by another 2 doses 12 hours later. Hello, so how many tablets are you going to give in a morning after pill? 2 doses? So, yeah, so it's 4. You're going to give 2 doses or 2 preparations of ethinyl estradiol and norgestrel. How many hours? 72 hours. Followed by another 2 doses 12 hours later. So, after 72 hours, 12 hours later, you are going to give the 2 doses. So, a total of 4 doses. My next question, what is the composition or component of your postcoital contraceptive pill? Okay. How about the morning after pill? Okay, so it is having what? Pure estrogen or a combination of progesterone? Oh, anak ba? So, very good, no? You have realized that, no? So, again, in a post-coital contraception, what is the component there? It is estrogen. How about in a morning after pill? Okay, and then you have to remember the process of giving that medication in order to have a sure ball, no? Nothing will be formed there, no? Especially in, okay? Okay, no evidence. Okay, so 2 doses of ethinyl estradiol plus norgestrel. I'm just giving you practical, no plot application. You have to remember that. How many hours? Okay, so your mathematics there is very important. Okay, adverse effects, restfulness, depression, dizziness, thromboembolism, thrombophlebitis, hypertension, myocardial infarction, CVA, cholestatic jaundice. Contraindications, CVA, estrogen-dependent cancer, liver disease, and migraine. Okay. Okay, so these are the drugs and dietary supplements that are used in the treatment of osteoporosis. Lang ha, I want to make sure. Okay. So what are your drugs and dietary supplements that are used in the treatment of osteoporosis? Number 1, alendronate. This will decrease bone turnover, inhibits osteoclastic activity. Can you still remember what are your bone cells? Osteoblasts, osteocytes, and osteoclasts. What are osteocytes? Bone cells. What are osteoblasts? Okay, what are osteoclasts? Okay, these are your bone resorption cells. Okay, so in alendronate, it will decrease bone turnover. It will inhibit osteoclastic activity. Okay, number two, calcitonin spray. It will interfere with osteoclast and inhibit bone resorption. Number three, calcium carbonate supplements at 1,200 milligrams per day. Then estrogen combined with a progestin and your SERM or raloxifene. Okay, so selective estrogen receptor modulator or SERM. Raloxifene, marketed as Ivesta, has a selective agonist or antagonist activity and the tissues responsive to estrogen. It will act as an agonist on the bones and partially on your cholesterol metabolism, and it can decrease your total and bad cholesterol. It is an antagonist on your hypothalamus or in the uterine and breast tissues associated with increased risk of venous thromboembolic event. So what is the use of raloxifene? Replacement therapy in climacteric or menopause. So therefore, this is very good for prevention of osteoporosis to decrease the symptoms of menopause. Okay, so raloxifene or Ivesta. The mechanism of action you have to know. So do you know now the mechanism of action of your SERM or selective estrogen receptor modulator, exemplified by raloxifene or Ivesta. So this is a supplement for a woman who is undergoing menopause. Okay, so let's go to your androgen agonist. And this is your testosterone and your anti-androgens. Okay, exemplified by flutamide as a receptor antagonist, finasteride as a 5-alpha reductase inhibitor, and then ketoconazole as a synthesis inhibitor, and your other oral GnRH agonist combined oral contraceptives. Okay, so where are we now? We have finished with estrogens and anti-estrogens, progestins and anti-progestins. Where are we now? Androgens and anti-androgens. I hope we have not slipped there, no? Okay. Testosterone is an androgen. This is principally secreted by the male testes, specifically your interstitial cells of Leydig. Can you still remember this in your histology? So 95% is secreted by the interstitial cells of Leydig. Then 5% in the adrenal glands, in the theca cells of the female ovaries, in the small quantities. Okay, there is no male ovary, di ba? So female ovaries. Now, secretion is controlled by growth hormone releasing hormone of the hypothalamus and the anterior pituitary. Okay, so luteinizing hormone is the one that will stimulate steroidogenesis. And follicle stimulating hormone will initiate your spermatogenesis. Most naturally occurring androgen, you have 8 milligrams produced daily with a range of 2.5 to 10 milligrams. And the plasma levels in the males is 0.6 milligrams per deciliter after puberty. That will decline at the age of 55. Now, other androgenic and anabolic steroids are the following: dihydroepiandrosterone, and letter B, you have your androstenedione. Now, these have both masculinizing and anabolic or growth stimulating effects. Okay? They possess the cyclopentanopenanthrin nucleus. Pharmacokinetics, you can give this orally, parenteral, and sublingual. 98 to 99% is bound to your sex hormone binding globulin, 1 to 2% in free form. The half-life is 10 to 20 minutes, rapidly inactivated in the liver with a biochemical modifications. Now, what are these modifications? Esterification, methylation, and halogenation. Okay. Okay, so what are examples of anti-androgens? You have leuprolide, gosirilin, nafarilin, bosirilin. These are your anti-androgens. These are growth-releasing hormone analogs. They reduce the production of testosterone by gonadal suppression. Clinical use of leuprolide, gosirilin, nafarilin, and bosirilin is in prostatic cancer. Mechanism of action, they will bind to your specific receptors in target tissues. Your hormone receptor complex will enter the nucleus and activate transcription of RNA for synthesis of protein involved in regulation of growth and cell division. Now, pharmacological effects, normal development of the male fetus and infants, masculinization of the genital tract. Now, for your androgens, biotransformation in the liver converts testosterone, androstenedione, and 17 ketosteroids to androsterone and ethiocallanolone. In target tissues, you have testosterone and dehydrotestosterone or DHT, which is your active metabolite by the enzyme 5-alpha reductase. And the excretion is through the kidneys. Okay, this is responsible for the major changes in males during puberty. Testosterone can increase the size of penis and testes, growth of the larynx and deepening of the voice. You have this already, no? You know this, no? Development of facial, pubic, and axillary hair, proliferation and increased secretion of the sebaceous glands, growth of bony skeleton, epiphyseal maturation and closure, darkening of the skin, enlargement of muscle mass and strength, spermatogenesis and sperm maturation, increased erythropoietin effect, and red blood cell production. Okay, clinical uses. Clinical uses of testosterone. Replacement therapy in male hypogonadism. Example will be testosterone enanthate, cypionate, propionate. This is given parenterally. And anemia to enhance red blood cell production by increasing production of your erythropoietin stimulating factor. Severe endometriosis to suppress estrogen secretion and function. Treatment here is danazole. In breast cancer, especially in females 1 to 5 years post-menopause. Others as potent anabolic agents in athletes and those with debilitating disease, as growth stimulators in prepubertal boys, aging in men to increase lean body mass, increase hematocrit, and decrease bone marrow turnover, osteoporosis alone with estrogen, prostatic hypertrophy, and cancer. Okay. So the second anti-androgen, you have here ketoconazole. This is an antifungal agent, steroid synthesis inhibitor, will inhibit your P450 enzyme, clinical use as a steroid-dependent metastatic tumor to suppress adrenal steroid synthesis. The third one is spironolactone. It is a competitive inhibitor of aldosterone. It will also compete with dihydrosterone for androgen receptors in the target cells. Clinical use, steroid-dependent metastatic tumor to suppress adrenal steroid synthesis, and then hirsutism in females. Okay, spironolactone. Finasteride is a 5-alpha reductase inhibitor and decreased formation of dihydrotestosterone. Clinical use of finasteride in BPH. What is BPH? Benign prostatic hypertrophy to decrease prostate size. Okay? Finasteride. Try to look in your drug index what is the brand name of finasteride. Okay? To decrease prostate size. Then cyproterone, derivative of progesterone, steroidal competitive inhibitor of androgens at the testosterone receptor, clinical use as an adjunct in the treatment of prostate cancer, treatment of precocious puberty in males, treatment of masculinization, and acne in women. Okay? So those are your anti-androgens. The most common used here is finasteride to decrease prostate size in benign prostatic hypertrophy. Flutamide and bicalutamide is a non-steroidal androgen antagonist that will inhibit androgens at testosterone receptors. Clinical use, prostate cancer to decrease the action of testosterone, excess androgen production in women. So those women who are having some excess hairs, bird, etc. So it will be to decrease masculinization. Okay, so we have here a case. 28-year-old woman. And he goes for a checkup to evaluate her infertility. So no children, not even pregnancy. So she is infertile. No? She and her husband has been attempting to conceive unsuccessfully for a year. She has never been pregnant. She has a history of irregular menstrual cycle, which were treated with oral contraceptive pills for 5 years. She has not taken contraceptives for the past 3 years. She has no other medical history. She takes no medications. And there is no family history of infertility. She does not smoke cigarettes or drink alcohol. Her routine, physical, and gynecologic examinations are normal. No? So it's actually from the hormones. No? The problem is in the hormones. Blood tests were also normal. Basal body temperature charts that she brings in with her show no mid-cycle temperature elevations. So there is no surge of luteinizing hormone. Okay? And home urine ovulation prediction tests have all been negative. Wala dyan, no? Her husband has already seen his physician, had a normal examination, and has had a normal semen analysis. So it's not a problem with the husband. It's really with the woman and the hormones that she is having, no? She is diagnosed with infertility secondary to anovulation and was started on clomiphene citrate. So we have already talked about clomiphene, no? Number one, I gave this already to you. Now, what is the mechanism of action of clomiphene? Number two, how does clomiphene induce ovulation? Can you still remember? What is the mechanism of action of clomiphene? What is the action of clomiphene? Clomiphene is a competitive antagonist of estrogen receptor. So actually, negative feedback, no? Number two, how does clomiphene induce ovulation? The mechanism of induction of ovulation by clomiphene is inhibition of estrogen feedback on the hypothalamus and pituitary with a resultant increase in your follicle stimulating hormone, which will induce follicle production in the ovaries, and consequently you will have ovulation. So actually the problem here is in the follicle stimulation, follicle production, and then induction of ovulation, which is done by your luteinizing hormone. Did you realize that? Okay. So here comes the problem with the use of clomiphene. Okay, clinical correlation. The menstrual cycle is regulated by your XPO or your hypothalamic pituitary ovarian axis, your gonadotropin releasing hormone, which is produced in the hypothalamus, will stimulate your pituitary hormones. What are your pituitary hormones? FSH and LH, which will now induce, with the case of FSH, maturation of your follicles from a primary follicle to a secondary follicle to a mature Graafian follicle, and then release of the ova from the ovaries by the luteinizing hormone surge. Did you understand that? So there will be release of a mature Graafian follicle from the ovary. So estrogen and progesterone produced in the ovaries will create a feedback loop and the hypothalamus and pituitary. So pause with that. Now, clomiphene, as I have said, is a competitive antagonist of the estrogen receptor. It is used for infertility in women who have anovulatory menstrual cycle. That means there is less amount of follicle stimulating hormone that is produced. So there is no follicle formation. That's why the patient is infertile. Okay, so anovulatory menstrual cycle. By antagonizing the estrogen receptor in the pituitary gland, clomiphene will disrupt the normal negative feedback on the release of your FSH. So the elevated levels now of your FSH will now help to induce the development of follicles in the ovaries. So that's how it will induce ovulation, with the help of your FSH and your LH. Did you get it? Okay, so what therefore are the potential risks with the use of clomiphene? Remember, you cannot just give this left and right. You have to more or less screen your patient and then monitor your patient. Number one, potential risk, stimulation of multiple follicles and release of multiple eggs with a resultant multiple gestation. So twinnings, triplets, quadruplets, quintuplets, sextuplets, you name it, no? So that's how it will affect your woman, okay? So you have to more or less orient the woman that you are going to give clomiphene. Because of this risk, is the woman prepared to have those multiple of fertilization because of the multiple follicles that have been released? Then it can also cause ovarian enlargement. Okay, tumors, no? Ovarian enlargement. The anti-estrogen effect also can precipitate. This is a common complaint of the woman on clomiphene, hot flashes, and abnormal uterine bleeding. So dysfunctional uterine bleeding or DUB. So you have to orient because the woman might be alarmed. Huh? Okay, so let's first learn some definitions. I already gave you about nuclear receptors. These are your receptors that are activated by your steroid hormones. And then SERM. SERM is selective estrogen receptor modulator. Okay, which will display a tissue-specific estrogen agonist or antagonist activity, which is exemplified by what drug? Can you still remember? Raloxifene or Evista. Then ERA or estrogen response element. Okay, this is a DNA sequence. Okay, so estrogens and progestins are gonadotropins and also sex steroids that will comprise a collection of drugs which have a number of uses. What are the uses of estrogens and progestins? Number 1, infertility. Number 2, contraception. Number 3, HRT or hormone replacement. Number 4, osteoporosis, which is exemplified by ranoxifene, and cancer or anti-cancer, which is exemplified by mifepristone and your finasteride. No? Antagonists acting within the system also have uses in treating hormone-dependent cancers and as abortive fashion. Now, take note, the menstrual cycle is controlled by a complex feedback system between the hypothalamus, pituitary, and the ovaries. Now, luteinizing hormone and follicle-stimulating hormone are released from the pituitary and stimulation by what hormone? Gonadotropin releasing hormone. Where is it released? Okay, very good. Okay, now your gonadotropic hormone, release hormone, is released from where? In what manner? It is in a pulsatile manner, under the control of a pulse generator in the neurons in the arcuate nucleus. Can you still remember your neuroanatomy? No? Arcuate nucleus. Okay? In the proliferative phase in the menstrual cycle, the pulse generator will cause a release of GnRH at a rate of 1 pulse per hour. Okay, so please try to more or less appreciate that. So how does a pulse generator act? It will cause your growth hormone, releasing hormone, to release your growth hormone at a rate of 1 pulse per hour. At this, there will be release of your luteinizing hormone and follicle-stimulating hormone from the pituitary, which is also regulated by your pulse generator. Please pause and try to imbibe the frequency of how your growth-releasing hormone is released from the hypothalamus. So what is the term there? Pulsatile. Okay? At a rate of 1 pulse per hour. Okay? So this intermittent release of your growth-releasing hormone is the key in controlling the menstrual cycle. Did you mention of this in your physiology? Okay, the K note there is pulse generator. pulse release of growth hormone at a rate of 1 pulse per hour, and at a rate of 1 pulse per hour, there will be release of luteinizing hormone and follicle stimulating hormone from the pituitary, which are also pulsatile. So the term here is it is not constant. It is intermittent. Okay? The intermittent release of growth hormone is a key in controlling the menstrual cycle because continuous infusion of growth hormone will result in cessation of release of your pituitary gonadotropins. That means cessation of the release of your follicle stimulating hormone and luteinizing hormone and estrogen and progesterone. So what happens here? The patient will have amenorrhea. So that's why there is an ovulation. Did you understand that? Is it very complex? The key term there is pulsatile. 1 pulse per hour. And intermittent. It is not constant. This is the key in controlling the menstrual cycle. And the reason here, it should not be continuous because there will be cessation of release of FSH and LH, estrogen and progesterone, if you give constantly or infuse constantly your gonadotropin releasing hormone. And this will result in amenorrhea. Because that will cancel your negative feedback mechanism, di ba? So, FSH, you know already, will act on the Graafian follicle to cause maturation of the ova, and your luteinizing hormone will cause an LH surge and will produce what? Ovulation. So that's how it is. Huh? So the word is pulsatile, intermittent, and will cause maturation of the Graafian follicle by your FSH and surge of your LH that can cause ovulation. Okay, so FSH will act on the Graafian follicle to cause maturation of the ova and secrete estrogen. As estrogen levels will rise, LH and FSH production is inhibited because of your negative feedback that will diminish the amplitude of your growth releasing hormone pulse. Release of FSH is also diminished by inhibition that is released by the ovary. So that is the rationale of release of your gonadotropin releasing hormone in a pulsatile manner. Now, at mid-cycle, alterations in the responsiveness of the pituitary to your gonadotropin will occur, and there will be a negative feedback pattern that is replaced by a period of positive feedback when you will have an increase in estradiol. Okay, so an increase in estradiol will cause release of LH and FSH. Now, this change in pituitary require the level of serum estradiol that should be above 150 pg per ml for 36 hours. The positive feedback now will elicit mid-cycle surge of LH and FSH. So there is really a mid-cycle surge of LH and FSH. So, surge of FSH can cause maturation of a Graafian follicle, and surge of luteinizing hormone can induce ovulation or the breaking up of the mature Graafian follicle and the release of a mature ovum. So, after ovulation, the corpus luteum now will be able to secrete progesterone for its lifetime of 14 days. If pregnancy does not occur. Did you get it? I repeat, after ovulation, the corpus luteum will be able to secrete progesterone for its lifetime of 14 days if pregnancy does not occur. Progesterone now will decrease the frequency of your hypothalamic pulse generator and therefore will inhibit your luteinizing hormone and follicle stimulating hormone release from the pituitary. So it's actually a cycle, no? Now, a frequent cause of infertility is a disruption in the complex feedback regulatory patterns that results in anovulation. Okay, so a disruption in this negative feedback mechanism can result in anovulation. Now, the ovary produces a number of estrogens. Now, the most important here is 17B, estradiol, and estrone. 17B, estradiol, and estrone are classical steroid hormones containing a 4-ring structure and 18 carbon atoms. Progesterone is also a classical steroid composed of 21 carbon atoms. Now, the effects of estrogen and progesterone are mediated by your hormone-specific nuclear receptors. Now, I already gave you what is the meaning of a nuclear receptor. There are two types of estrogen receptor. You have your ER alpha and ER beta. Okay, so estrogens and progesterones have a variety of pharmacological uses. I have given already to you oral contraception, HRT, or hormone replacement therapy. Postmenopausal women, treatment of osteoporosis, and failure of ovarian development. Okay, so oral contraceptives. Let's now go into oral contraceptives. What are oral contraceptives? They are combination containing synthetic estrogens. What is the most common preparation here that is in combination will be ethinyl estradiol. And most commonly in your progesterone or progestin, it will be norethindrone or norgestrel. So I repeat, in the case of synthetic estrogens, it will be ethinyl estradiol. And for progesterone or progestin, it will be norethindrone or norgestrel. Now, over the past several years, the doses of estrogen in combination oral contraceptives have already diminished, and the ratio of estrogen to progestin has already evolved from a fixed, which is otherwise termed as monophasic, to a multiple or biphasic. So the recent trend now is not a fixed combination. It is more or less a biphasic and triphasic regimen. So biphasic to combination, estrogen and progesterone, and triphasic, it could either be 2 estrogens, 1 progesterone, or 1 estrogen, 2 progesterone, with varying ratios. What is the rationale for this? They are having a not fixed combination. It's already a varying amount of progesterone in order to closely mimic the ratio during the normal menstrual cycle, because the amount of progesterone and estrogen in a woman will be variable. So that's why they are more or less going into biphasic and triphasic regimen. Again, what's the rationale here? Not a fixed combination anymore. It's to copy or mimic the ratio during the normal menstrual cycle. It depends on the content of progestin and estrogen in a woman's body. Okay. Now, what is the primary mechanism of action of oral contraceptives? It is prevention of ovulation. Now, your mid-cycle LH surge is absent and endogenous estrogen levels will be reduced. Now, oral contraceptives can also alter the transport of the ovum down the fallopian tube. It will increase the viscosity of the mucus. I already gave you this, no? Produced by the cervix. This is your mechanism of action of the oral contraceptives, no? I repeat, it will alter the transport of the ovum down the fallopian tubes. Number 2, increase the viscosity of the mucus produced by the cervix, which will impair sperm entry and transport and create an endometrial environment that is less favorable to implantation. So there will be thickening of the endometrial lining that will be less favorable to implantation. And then also viscosity of the mucus in the cervix is increased. That will more or less impair sperm entry. Can you relate with that? No? And then alter the transport of the ovum down the fallopian tube. So it will influence now the linings of the fallopian tube. That will make it very difficult for the ovum from the ampulla, as it is catched by the fimbriae during ovulation. It will be difficult to transport the ovum from the fallopian tube, from the ampulla of the fallopian tube to the uterus, because it will now alter the linings of the fallopian tube. So that is the, those are the effects of your oral contraceptives. Okay, so mechanism of action of your oral contraceptives. Okay, now progestin, this is the only contraceptive that may be administered as a daily oral dose. Then you have also a depot injection, presented as medroxyprogesterone acetate or as an implant, your progestin L-norgestrel. I repeat, what are your preparations of your progestin as contraceptive, not only orally, but also, number 1, oral dose. Number 2, depot injection. What is the progestin form here? Medroxyprogesterone acetate or as an implant. So what is this implant here? L-norgestrel. So you have this in our guide, in our overview, that this is an androgen, no? Oh no, progesterone preparation. And I gave you that this is your prototype drug, which is L-norgestrel, that is given by implant. Okay, so the effectiveness approaches combination oral contraceptives, and both your depot injection and your oral injection have the advantage of a long duration of action. So 14 weeks for the injection, 5 years for the implants. So you want an implant? Okay, for contraception? I don't know what will be your purpose here of having an implant. Kamo, ganahan mag-implant. Okay, it's too long, no? 5 years. Unless it is a therapeutic indication that it can harm the health of the woman. Diba? Congenital problems, congenital heart defects, no? That means you have to discourage pregnancy in that woman, okay? So you can do with implants, no? Now, progestin alone can inhibit ovulation about 70% of the time, but their effectiveness is increased by their effects on the endometrium and your cervical mucus production. Now, there are also morning after contraceptive regimen that has been used effectively to prevent pregnancy, which consists of 2 combination oral contraceptive pills containing 50 micrograms of ethinyl estradiol and 500 micrograms of norgestrel. That is taken immediately at 2 and 12 hours. Okay? So alternative schedule can include 2 doses of 750 micrograms of L-norgestrel over 1 day. So these are variability of your intake of your morning after pills. Okay? So for hormone replacement therapy, after menopause, you know already that there will be a decline of your estrogen levels. And this is associated with an increased bone loss that can result in osteoporosis. The patient can have vasomotor symptoms such as hot flashes and night sweats, vaginal dryness and thinning, and genital atrophy. So all these symptoms can be mitigated with the use of estrogen replacement therapy. But I have already given to you what will be the contraindications for the use of your hormonal replacement therapy. So you have to be very careful. Careful assessment of the risk-benefit ratio for a given patient is very essential. Okay? So what is this most commonly prescribed oral estrogen preparation for both menopausal therapy? What is this? Okay. So the most commonly prescribed oral estrogen preparation for both menopausal therapy is a complex mixture of natural estrogens. You have your conjugated equine estrogen or Premarin, which is mostly your estrone sulfate and equine estrogens. And this is combined with what? Medroxyprogesterone acetate to avoid unopposed estrogenic stimulation of the endometrium. Again, what will be your combination here? Ethinyl estradiol with medroxyprogesterone acetate. Okay? So other HRT or estrogenic replacement therapy regimens can include, number one, oral esterified estrogen. Number two, micronized estradiol. And number three, a transdermal delivery of estradiol. Okay, so other uses of estrogens and progestins. Estrogens can be used to treat circumstances of inadequate hormone production, as in primary hypogonadism. This treatment now will begin at early ages 11 to 13 to facilitate the development of your secondary sexual organs and to stimulate maximal growth. Okay? They are very useful for intractable dysmenorrhea, where inhibition of ovulation may be of therapeutic value. Now, high doses of estrogen also has been used to suppress ovarian production of androgens. Now, these therapeutic approaches can depend on your estrogen-mediated negative feedback inhibition of gonadotropin release. Okay, so negative feedback. Now, what are the adverse effects of estrogens and progestins? Now, most of these adverse effects are extensions of their physiologic actions. Uterine bleeding is the most common adverse effect associated with the use of estradiol or estrogen. And then you can have also an increased risk of cancer caused by estrogens and progesterones. Unopposed estrogen treatment has been well documented to cause a threefold increase in the risk of endometrial cancer. Addition of a progestin to a treatment regimen essentially can eliminate this increased risk. So this is very important here to have a combination therapy in order to decrease the risk of endometrial cancer. And this is taken care of by progesterone or progestin. Okay, now there has been some clinical trials that examines the use of estrogen to treat your postmenopausal women because of an increased risk of breast cancer with progesterone and estrogen treatment. So the absolute number of breast cancers that can be attributable to your hormone replacement therapy was very low. These studies can also show that estrogens decrease the risk of endometrial, ovarian, and colon cancer. So you have to get the net effect of the levels of your estrogen and progesterone that you are giving in order to more or less, especially with progesterone, which can eliminate the risk of endometrial cancer. So you have to really weigh your use of your oral contraceptives and more or less try to look for a very good screening of your patients that you are about to give with an oral contraceptive. Okay, so it has been said that your estrogen can improve serum lipid levels by decreasing your low density lipoproteins, which are considered as your bad cholesterol, but it is not really very amusing, no, with the result. So it said that estrogen can increase your high density lipoproteins and can decrease your low density lipoproteins, which are considered as your bad cholesterol. With your anecdotal evidence, it has been found out that your Primarin or Primro does not reduce the risk of cardiovascular disease. So you have to be very careful in a patient that you are about to give with an oral contraceptive or a hormone replacement therapy, especially if the patient had been having cardiovascular problems, especially stable angina, unstable angina, or a history of myocardial infarction. So you have to be very careful in giving this hormone replacement therapy in these patients. So there has been an indication that there is an increased risk of MI and stroke, especially in the first years of treatment of your hormonal replacement therapy. So the underlying mechanism for this is although unclear, but it can involve an increased coagulability with an association with estrogen treatment. Okay, I repeat, you have to be very careful in giving hormonal replacement therapy in a woman who has already a previous history of unstable angina or myocardial ischemia or myocardial infarction, because the risk is correlated with the increased coagulability of the blood component associated with estrogen treatment. It has been found out that estrogens can do the following. Number one, increase the synthesis of fibrin and coagulation factors 2, 7, 8, 9, and 10. I repeat, why is it very risky to give hormonal replacement therapy in patients with a history? The woman has a history of unstable angina, myocardial infarction, myocardial ischemia because of an increased coagulability that is associated with estrogen treatment. Then it can increase the synthesis of your fibrin and coagulation factors 2, 7, 8, 9, and 10. And it can decrease the concentration of your antithrombin 3. So please try to review. You have this in your physiology. What are your coagulation factors? Your extrinsic and intrinsic pathway. Hello. I know that our focus here is with the drugs, but it is you cannot more or less avoid that you have to go back to your major subjects, no, in the first year. So physiology, histology, anatomy. These are your prerequisites before going into pharmacology. Because we cannot really discuss everything without going back to where we belong. Okay? So estrogens, decrease the concentration of antithrombin 3. Review your coagulation factors. Okay? Can I get a yes? Okay, so those are the probable risk of giving your HRT in patient women who have a previous history of cardiovascular problems, plus your plasminogen activator inhibitor is increased. Plasminogen activator inhibitor. These changes in the woman's blood can contribute to a heightened tendency to form blood clots. Okay? This mechanism may also participate in the increased risk of dementia in postmenopausal women treated with estrogens. Imagine that you are having an hormonal replacement therapy in order to avoid hot flashes and what else? Vasomotor symptoms, but you have also an increased risk of dementia. Do you want that? What is dementia? Gradual loss of memory. Okay, you want that? I better have my memory. I will go with the vasomotor symptoms, hot flashes, etc. Di ba no? Those are just discomfort, minor discomfort, but dementia is a major discomfort, di ba? I will not know you already in the next few years. No? You want that? Okay, so dementia, especially with serious adverse effect with premarin or premarin plus progesterone at a fixed dosage. Okay, now less serious adverse effects of estrogens can have nausea and vomiting, peripheral edema, severe migraine. How would you like that? Dementia versus vasomotor symptoms. Okay, for your anti-estrogens and SERMs, there are two compounds, clomiphene and fulvestrant. Diba? I already gave this to you. These are your pure anti-estrogens that will antagonize the action of estrogen in all tissues examined. As I've said, clomiphene is a triphenyl ethylene consisting of two isomers, your cis-clomiphene and trans-clomiphene. Cis-clomiphene is a weak estrogen agonist, whereas trans-clomiphene is a potent antagonist. And here, your clomiphene will bind to both your ER alpha and ER beta and will block estrogen activation of these receptors. So the major pharmacologic action, therefore, of clomiphene is to block your estrogen-mediated negative feedback in the pituitary. And this will increase the amplitude of your luteinizing hormone and follicle-stimulating hormone. And will induce ovulation in women with amenorrhea. You have your Stein-Leventhal syndrome and dysfunctional bleeding with anovulatory cycles. It will also increase the number of ova released, thereby increasing the chances of twinning. So that is the action of clomiphene. Whereas fulvestrant is a 7-alkylamide derivative of estradiol that will bind to both your ER alpha and ER beta. It is administered as a depot injection. The predominant action of fulvestrant is to increase the degradation of your ER alpha while having little effect on your ER beta. This alteration in the ratio of ER alpha and ER beta may explain the usefulness of women with tamoxifen-resistant breast cancer. So in breast cancer, any questions so far? Adverse effects of your anti-estrogens will include hot flashes, ovarian enlargement, and nausea. Okay, for the SERMs, you have tamoxifen, raloxifene, and torimifene. These are your compounds that display a range of agonist to antagonist activities in a tissue-specific manner. So, tamoxifen is an estrogen receptor antagonist in the breast, but is a weak estrogen agonist in the endometrium. So that's why they are termed as tissue-specific. So therefore, you have a tissue specificity in the case of your SERMs. What is the meaning of SERMs? Okay. combination of drug-induced conformational changes in the receptor and the complement of your co-activators, which are expressed in a given cell type, and that explains the tissue specificity. Okay, so what happens when estradiol will bind to your estrogen receptor? There will be an activation between your co-activator protein and your estrogen receptor. Once they will now bind to your estrogen receptor, there will be a change that is different from your estradiol. And this will express a co-activator that will recognize a particular configuration. So for example, tamoxifen, which is used for breast cancer, it is structurally related to diethylstilbestrol, and they will bind to both your ER alpha and ER beta. It will act as an estrogen antagonist in the breast and in the brain, but it is a weak estrogen activity in the uterus. So therefore, it has a mixed action. Okay? It is highly efficacious in the treatment of breast cancer. And it has been shown to increase disease-free survival and overall survival. Treatment for 5 years has reduced cancer recurrence by about 50% and death by 30%. So its cause of the development of drug-resistant tumors, treatment should last for no more than 5 years. Adverse effect of tamoxifen can include flushes, nausea, and vaginal bleeding. Okay, so that is tamoxifen. What is tamoxifen? Classify tamoxifen. Under your
SERM.
Sondo.
under your what? Estrogen antagonist, progesterone antagonist, or androgen antagonist? Huh? Tamoxifen? Really? Naglibog naman ni sila. I will go back to the kuan ha. Ito. That is why I ask you to remember. Oh, where is tamoxifen in that one? Wala. Huh? It serves lagi, pero under what group of your agonist and antagonist?
Estrogen box.
There are some who answered androgens. There are some who answered progesterone. That's why I told you to memorize this kuan, huh? You are like a bridge over troubled water. Huh? So this is, that's why I do this. I did this for you to have a guide, no? So that you will not go into something not correct, no? So what is it? Okay, estrogen antagonist under what terms? Allah. If we will do matching type for this, no, it's very, or multiple choice, it's very cool, no, very easy for you, no, to fall into very, okay? I thought you memorized this koan, no? I purposely did this for you to have a guide. And for sure, you will go distracted. At 15 minutes before 11, you will have a post-test, huh? It will be given by Dr. Alarcon. Okay, so we are here, no? I ask you to classify tamoxifen. And you give me an answer, anti-progesterone. Oh, no, because you already know. Because I already... okay. Oh. Finasteride, what is it? Finasteride, huh? Okay, yeah, it's 5-alpha reductase inhibitor. But what is it? Anti-progesterone, anti-androgen? Huh?
Anti-androgen.
Okay. So that's why I'm... Okay. Oh, we have here torimifene and raloxifene. Okay. Torimifene and raloxifene. It is also used for the treatment and prophylaxis of breast cancer. Raloxifene is a polyunsaturated nonsteroidal compound with a benzothiophene core. It will bind with high affinity for both ER alpha and ER beta. It is a very strong agonist in the bone where it exerts an anti-resorptive effect. So this is used for osteoporosis. It reduces total cholesterol and LDL cholesterol. Raloxifene does not have an agonist activity in the uterus. Its primary use is the prevention of osteoporosis in postmenopausal women. Adverse effects, hot flashes, deep vein thrombosis, and cramps in the lower extremities. Antiprogestins, you have one only, no? Mifepristone. So it is an antiprogestational and anti-glucocorticoid effect. It is most commonly as an abortifacient in the first trimester of pregnancy. Okay? Antiprogestin, it can be used as abortifacient in the first trimester of pregnancy. A single oral dose of mifepristone, now you know, no? Combined with a vaginal suppository containing prostaglandin E is very effective in terminating pregnancy in about 95% of cases if used in the first 7 weeks of gestation. Oh, are you developing horns now, no? I know already how to terminate the pregnancy in the first trimester. Huh? I'm not inducing you to do that, but I was just relaying this knowledge that this can be an antiprogestin. Huh? Okay, abortifacient, first trimester of pregnancy, single dose only, and then combined with a vaginal suppository containing prostaglandin E. It is very effective in terminating pregnancy in about 95% of cases if used in the first 7 weeks of gestation. How many weeks are there in 1 month? 4. So 7 weeks is what? How many months? 1 3/4. Okay, 1 3/4 month. Adverse effect, vomiting, nausea, and abdominal cramping. Okay, androgens and anti-androgens. The testosterone is the one that is produced in the testes. This is the major androgen in humans. In male peripheral tissues, testosterone is converted to dihydrotestosterone by the enzyme 5 reductase. Now, most circulating testosterone is bound in the plasma to your SSBG or your sex steroid binding globulin. Testicular production of testosterone is regulated by LH released from the pituitary in a manner similar to that of your estrogen. Testosterone has 2 physiological actions. Number 1, as an anabolic agent because it promotes linear bone growth, development of internal genitalia, and increased muscle mass. Number 2, as an androgenic agent responsible for the development of your male secondary sexual characteristics. Dihydrotestosterone is responsible for the development of external genitalia and hair follicle growth during puberty. Testosterone or dihydrotestosterone will bind with high affinity to the androgen receptor or AR, which is another member of your nuclear receptor family of transcription factors. There are two distinct chemical classes of androgens. You have testosterone and its esters and the 17-alkyl androgen. Now, testosterone esters includes testosterone enantioate, testosterone cypionate, and testosterone androxynoate. The 17-alkyl androgens can include your methyl testosterone, oxandrolone, danazol, and stanozolol. I know you have met this word danazol, so you try to classify this. Okay? We're almost due, no? Okay? They are administered either as depot injection via transdermal patch or a gel. I repeat, how can you give your testosterone? Either as depot injection, transdermal patch, or as a gel. Your 17-alkyl androgens are orally active. Now, the major uses of your androgens. Number one, treatment of male hypogonadism in adults and in pre-pubertal boys that have a very low amount of testosterone. Use in adults has been reported to, number one, increase libido, number two, reduce senescence, and number three, reduce the rate of bone resorption. The major adverse effects of testosterone and its esters are caused by the androgenic actions, which are especially apparent in your women and in prepubertal children. In women, these adverse effects includes hirsutism. You are a woman. Do you want to have this? Hirsutism, acne, amenorrhea, thickening of the vocal cords in children. Androgens can cause premature closure of the epiphysis. In men, androgens can produce azoospermia, decreased testicular size, and prostatic hyperplasia. The major adverse effect, therefore, of your androgens can be masculinization and serious hepatotoxicity. And you can have also a cholestatic jaundice that is reversible and discontinuation of the drug. So those are your adverse effects. So let's go to your anti-androgens. Abnormal growth of the prostate is usually dependent on your androgen stimulation. This hormonal stimulation can be reduced by, number one, orchidectomy. What is the meaning of orchidectomy? Removal of the orchids. Huh? What is orchidectomy? Okay, removal of the testes. Okay? It's not removal of the orchids, huh? Can you say ectomy means removal? Yeah, the word there is orchids. The removal of the orchids. No? It's not correct, by the way, you know. It's removal of the testes. Number two, high doses of estrogens. Okay? Then number three, chemical orchidectomy. How do you do chemical orchidectomy? By giving an inhibitor of growth hormone releasing hormone synthesis, such as leuprolide, or with an anti-androgens. Okay? So, what drug are you going to give in chemical orchidectomy? Leuprolide. Okay? Then finasteride is a steroid derivative that will competitively inhibit your 5-reductase type 2. And since prostate growth is dependent on your DHT rather than testosterone, blockade of this enzyme can reduce the size of the prostate. So finasteride is used to reduce the size of the prostate in cases of benign prostatic hypertrophy. So finasteride has been used to decrease the incidence of prostate cancer, and have led to aggressive tumors. Then bicalutamide, nilutamide are your potent anti-androgens. They are usually combined with analogs such as leuprolide or growth hormone releasing hormone analogs to decrease your luteinizing hormone and reduction of your testosterone production. Flutamide is an AR antagonist that will block the action of testosterone in your target organs. It has been used in the treatment of prostatic carcinoma. We're almost there. Okay. Okay, so these are the study guide for you. No, understand the structures, mechanism, and action and effects of your natural gonadal hormones. So you have to review your physiology, anatomy, and histology. Number 2, know the therapeutic uses and adverse effects of estrogen, progestins, and androgens. List the types, uses, and adverse effects of hormonal contraceptives. Describe the drugs used as anti-estrogen, anti-progestin, and anti-androgens, their therapeutic uses, mechanism of action, and adverse effects. So these are now your pharmacology pearls. You have to know that clomiphene is an agent of choice for treatment of infertility as a result of anovulation in women with an intact HPO or your hypothalamic pituitary ovarian axis. SERMs are tissue-specific estrogen antagonists that have uses in the treatment of breast cancer and osteoporosis. And then anti-androgens are used to treat androgen-dependent cancers such as prostatic carcinoma. Okay, where is she going? CR? Okay, I will wait. I will give you a sample question, huh? You will have your STEM. What time? What time is there? I will give you 3 sample questions. They might come in your post test, no? So I have to wait for him. Okay. We are going to have your post test at 10:45, no? And it's now 10. I will give you sample questions. Huh? There are only 3, no? That will take your about 8 minutes, no? Sample assessment question with rationale. Number 1, clomiphene acts to induce ovulation by letter A, diminishing estrogen receptor-mediated negative feedback at the pituitary. Letter B, increasing the action of